Welcome to the deep dive. Today we're tackling a topic that comes up all the time in pediatrics. Childhood diarrhea. We've got this stack of notes here, really high-yield stuff, perfect if you're revising or just need a clear understanding.
Exactly.
Think of this as us helping you pull out the absolute must-knows from these notes.
Yeah, trying to make it stick without getting bogged down in, well, too much detail.
We'll cover what it is, the causes, who's most at risk, what's actually happening in the body.
How to spot it, investigations, management, and really importantly, complications and prevention, all based on what's in front of us here.
Right. Our mission is just to make sense of this material for you.
Let's do it.
Okay, let's open these up and jump straight in. So, first up, the definition. According to these notes, what exactly is childhood diarrhea?
Okay, so the notes define it pretty clearly. It's the passage of loose, watery stools, and the key is 3 or more times a day. So frequency matters.
3 or more times, got it.
Yeah. And it's flagged as a super common gastrointestinal symptom, can be acute, sudden onset or chronic, meaning it lasts longer.
Right.
And the notes stress it's often infection-related, mostly viruses.
Yeah.
But other things can cause it too, like problems absorbing food or even rarer stuff like endocrine issues.
Okay, so not always a bug.
No. And straight away, the notes highlight the main danger of acute diarrhea. Dehydration, losing too much fluid. That's the big one.
Dehydration. Okay, so loose, watery, frequent stools, often infection. Dehydration's the main worry. What about those non-infectious causes? When do we really start thinking about them?
Well, the guidance here is pretty clear. If the diarrhea drags on for more than 14 days, or if it keeps coming back, that's your cue to think beyond infectious.
2 weeks of recurring. Okay.
Yeah. And there are specific red flags listed too, things that sort of shout, this isn't just a simple viral bug.
Like what?
Things like the child seeming generally really unwell, not just a bit off, significant tummy pain, signs of shock, obviously, green vomit, bilious vomiting, or seeing blood in the stool. Those really point away from your standard viral gastroenteritis.
Those flags sound absolutely crucial to pick up on. Right, so it's often infection, but could be other things. Let's dive into the causes listed here. Looks like a pretty long list.
It is, yeah. The most common cause mentioned is gastroenteritis, and under that umbrella, you got your viruses. Rotavirus, norovirus are big ones. Bacteria like Shigella, Salmonella, Campylobacter, and even protozoa like Giardia.
Okay, the usual suspects for gut infection.
Right. But then the notes point out that infections outside the gut can trigger diarrhea too. Systemic infections.
Like what?
Things like UTIs, pneumonia, ear infections, even meningitis or septicemia, especially in younger children.
Wow, okay. Didn't immediately think of those.
Yeah, it's important. Then there's antibiotic-associated colitis, obviously from taking antibiotics.
Oh, right.
Dietary issues, food allergies, intolerance to lactose or cow's milk protein. And this interesting one, starvation stools.
Starvation stools. Tell me more about that one.
It's often seen when a child isn't getting enough nutrition. The gut isn't working properly, leading to loose stools.
Okay. What about surgical problems? Can they cause diarrhea?
Yes, definitely. The notes list surgical conditions like appendicitis, intussusception where the bowel telescopes, Meckel's diverticulum, bowel obstruction. Diarrhea can sometimes be a feature.
Okay.
Then you've got malabsorption disorders, things like cystic fibrosis, coeliac disease, inflammatory conditions, ulcerative colitis, Crohn's disease.
Chronic conditions, yeah.
And finally, a sort of miscellaneous group. Constipation, oddly enough, can cause overflow diarrhea, HUS hemolytic uremic syndrome, toddler's diarrhea, which is usually benign, and even hyperthyroidism.
Gosh, that's a really broad range. I see the notes make a specific point about bloody diarrhea. What are the main things to think about there?
Yeah, this is highlighted as important. For bloody diarrhea, the notes point strongly towards certain bacteria. Campylobacter species, especially C. jejuni.
Okay.
And verocytotoxin-producing E. coli VTEC 0157. Those are key causes of bloody stools.
VTEC 0157.
Got it. And the notes helpfully break down common causes by age, which is useful for narrowing it down.
Oh, good. How so?
So for infants under 1 year, you're mostly thinking intestinal infections, maybe infant colitis or reactions to milk, less commonly things like NEC or Hirschsprungs.
Okay.
For older children over 1, infections are still common, but you also think more about inflammatory bowel disease like Crohn's or UC or maybe a juvenile polyp. The rarer causes shift a bit too.
That age breakdown is really handy. So that list of causes really shows us not just one thing. Who's most vulnerable? Who's most likely to get diarrhea? What do the notes say about risk factors?
Right, so the notes give a pretty comprehensive list here. A lot of it comes down to environment and exposure, as you might expect.
Sounds like it.
Like poor sanitation and hygiene, obviously,
Uh-huh.
consuming contaminated food or water, being in close contact with someone else who's infected.
Standard infection spread.
Exactly. Then there's inadequate breastfeeding, not exclusively breastfeeding or stopping early. Breast milk has protective factors. Immunodeficiency, any child with a weakened immune system is more susceptible.
Makes sense.
Travel to high-risk areas is a big one.
Traveler's diarrhea.
Yep. Overcrowded living conditions. Low socioeconomic status, often linked to poor access to clean water, healthcare, good nutrition.
Right. Those factors often cluster together.
They do. Malnutrition itself weakens the immune system. Any pre-existing medical condition that compromises immunity.
So-
Exposure in places like playgrounds or childcare centers where bugs spread easily. Lack of vaccinations, specifically mentioning rotavirus vaccine here.
Prevention starting there.
Yeah. And basic stuff like unsanitary food handling at home or just poor personal hygiene, like not washing hands properly.
Hand washing, always key.
Always. And finally, seasonal variation. Some bugs are just more common at certain times of the year.
So a lot of interconnected factors: hygiene, access, nutrition, immunity. It paints a clear picture.
It really does.
Okay, so we know what it is, the potential causes, who's at risk. But what's actually happening inside the gut? How does this cause diarrhea? What's the pathophysiology according to these notes?
The notes keep this bit quite focused, actually. It boils down to an imbalance.
An imbalance of what?
Fluid, an imbalance between how much fluid the intestines absorb and how much they secrete or push out.
Yeah.
Infections, or these other triggers we mentioned, basically disrupt the normal way the gut works.
This is up to system.
Exactly. And the result is increased loss of fluid and electrolytes, those important salts in the stools. That's the core mechanism.
So the gut lining gets irritated or damaged, it can't absorb water properly, or it actively pumps out water and salts, leading to watery stools and the risk of dehydration.
Precisely.
No.
Simple concept, but critical consequences.
Absolutely. Now, with that huge list of causes we went through, telling things apart, figuring out the specific cause, that sounds tricky. What does the differential diagnosis section offer?
Yeah, it can be a puzzle. This section basically lists the main things you need to consider to rule out when a child presents with diarrhea.
Kind of like a checklist.
Sort of, yeah. It lists gastroenteritis, the common one we keep mentioning, malabsorption disorders, inflammatory bowel disease, lactose intolerance, celiac disease,
Right.
and then a general category of other gastrointestinal infections or disorders.
So it largely mirrors the causes list, but framed as what else could this be?
Exactly. It's about keeping those possibilities in mind during assessment.
Right. Okay, shifting gears slightly. How common is childhood diarrhea? The notes mention the UK specifically.
They state very clearly that it's a common condition in the UK. Very common.
Okay.
And it's particularly prevalent in the under fives. That age group really bears the brunt.
Under fives.
Yeah. And, confirming what we said earlier, viral gastroenteritis is noted as being a frequent cause specifically in the UK.
So very common, especially in the little ones, often viral. Good context to have. Let's talk about what you actually see. What does a child with diarrhea look like? What are the key symptoms and signs the notes tell us to watch for?
Well, you have the obvious common symptoms, right? Frequent loose stools, often tummy cramps and bloating, maybe a fever, feeling sick, vomiting.
The typical picture.
The typical picture. But the notes really emphasize recognizing the signs of dehydration. This is hammered home.
Okay, what are those key signs again?
Dry mouth. Passing less urine than usual, fewer wet nappies in babies. Lethargy, just seeming floppy or lacking energy. And sunken eyes. Those are really important flags.
Dry mouth, less wee, lethargy, sunken eyes. Got it. Crucial.
Absolutely crucial. The notes also add other details to think about. Does the child have systemic symptoms affecting the whole body, not just the gut? Are other family members ill?
Right. Clues about infection spread.
Exactly. And noting any abdominal pain, though it's often nonspecific in simple viral cases, they also prompt you to consider exposure history.
We mentioned travel and animal.
Yeah, and water exposure, like swimming pools.
Yeah.
All useful clues.
So looking at the whole picture,
Yeah.
not just the diarrhea itself.
Definitely. And the notes really stress the severity signs. Recognizing dehydration is critical because it can lead to shock, even coma.
Serious stuff.
Very. Failure to thrive and malnutrition are mentioned as longer-term issues. And there's that specific warning again. Urgent assessment needed for focal abdominal pain. Could be surgical.
Okay, that point about focal pain really stands out. So Given all these possibilities and the need to spot severity, what investigations are typically done? What do the notes suggest?
Well, the notes say diagnosis is often clinical, meaning you can often figure out it's likely straightforward diarrhea just from the history and examining the child.
So tests aren't always needed.
Not always for simple, mild cases, but additional tests may be used. The main one listed is stool analysis.
To look for bugs.
Exactly. To try and identify specific bacteria or parasites causing the trouble.
Okay.
Rotavirus antigen tests get a mention, but with a big caveat. They can have false negatives and false positives, so not foolproof.
Okay. Good to know. What about blood tests?
Blood tests listed include a full blood count, FBC. Often normal, but might be raised in bacterial infections. Urea and electrolytes UNEs are vital.
For hydration.
Yes, assessing hydration status and checking electrolyte balance. Crucial. Liver function tests, LFTs, are mentioned too, maybe looking for protein loss from the gut.
Right.
And then it says additional tests depend on the case. If you suspect coeliac, you might check endometrial antibodies, or maybe an intestinal biopsy or a sweat test for CF if suspicion points that way. Tailored investigation.
So start clinical, maybe stool test, definitely UNEs if concerned about hydration, and then specialist tests based on suspicion. Makes sense. So we've assessed, maybe investigated, how do we manage childhood diarrhea according to these notes? What's the plan?
The management section is crystal clear. The absolute main focus is rehydration therapy and supportive care. That's the cornerstone.
Rehydration, rehydration, rehydration.
Pretty much. Using oral rehydration solutions, ORS. Those special drinks with the right balance of salts and sugar. Or if dehydration is severe or the child can't keep ORS down, then IV fluids are needed.
Okay.
And the notes specifically highlight paying extra special attention to hydration in infants under 6 months. They dehydrate much faster.
Very vulnerable group.
Very. Breastfeeding is noted as beneficial. Definitely continue breastfeeding if the baby has diarrhea.
Good. What about antibiotics?
Rarely needed. The notes are firm on this. Most cases are viral. Only use them if you've actually identified a specific bacterial or protozoal infection where they're known to help.
So no routine antibiotics.
Definitely not. Loperamide, that anti-motility drug, is mentioned, but with a strong caution. It might reduce stool frequency a bit, but it's rarely prescribed due to unclear side effects, especially in kids.
Okay. Avoid loperamide generally.
That's the message. Now, hospital admission. There are clear indications listed.
When does a child need to come in?
If there are concerns about the underlying diagnosis, maybe one of those red flags. Dehydration, especially moderate and severe, and again, especially critical in infants under 6 months. If the child just can't manage oral rehydration at home, or if they have other medical problems made worse by the diarrhea.
Clear triggers.
Yes.
Yeah.
And urgent specialist advice is needed for acute bloody diarrhea, suspected VTAC 0157, or significant dehydration. Get help quickly.
Right.
And a really important point, what not to give before referral. No antibiotics, no NSAIDs like ibuprofen, no other painkillers, and no antimotility drugs. Don't muddy the waters before they see a specialist.
Okay, keep it simple, focus on fluids, and know when to call for help.
Exactly. Oh, and finally, report infectious bloody diarrhea to the local health protection unit, public health measure.
Got it. That management strategy is very practical, focused on fluids and safety netting. Okay, what about the bigger picture? Prognosis, what's the typical outcome? And prevention. How can we stop this happening so much?
The notes are generally positive on prognosis, usually good with proper management. Most kids recover fully.
It's reassuring.
It is. But they repeat the potential complications. Dehydration, electrolyte problems, malnutrition, more likely in severe or prolonged cases.
So the complications are the main caveat.
Yes, which leads to prevention. Prevention is key. The notes list several methods.
Like
Good old food hygiene, hand washing simple but so effective, and excluding kids with diarrhea from nursery or childcare to stop the spread.
basic public health stuff.
Yeah. And vaccination routine, rotavirus vaccine is mentioned again, plus travel vaccines like typhoid for kids going to high-risk areas.
So prevention is multifaceted. Hygiene, exclusion, vaccination.
Exactly.
You mentioned complications a few times as a big concern. Let's just focus on that list specifically. What potential problems do the notes detail in the complications section?
Right, it's good to reiterate these. The primary ones are dehydration, electrolyte imbalances, and malnutrition. Prompt treatment prevents these, the notes say.
Okay, the big three. What else?
They list temporary lactose intolerance, quite common after infections like rotavirus or Giardia. The gut just needs time to recover.
Oh.
Rarely, the bacterial infection can spread beyond the gut, causing septicemia or meningitis. Very serious.
Wow.
Uncommon but serious complications include bowel perforation, intussusception, appendicitis, even a liver abscess.
Wow.
And then rare ones like hemolytic uremic syndrome, HUS, linked to kidney failure, and reactive arthritis.
HUS keeps coming up.
It does. Chronic fat malabsorption can happen, especially after Giardia, and kids can become carriers for bugs like rotavirus or salmonella even after they seem better.
Right.
And that specific link is made again. E. coli O157 is a common cause of HUS, and that hemorrhagic colitis, the bloody diarrhea.
That list really drives home why managing this properly and spotting those red flags is so vital. Usually okay, but potentially serious.
Absolutely. So we've kind of taken a deep dive through these notes, definition, causes, risks, the how, the what, investigations, management, outcome, and those crucial complications.
Yeah, it feels like we've covered the key ground. It's clear that while often mild, spotting dehydration and knowing those red flags for serious causes is like the highest yield thing for you to take away.
Definitely.
And prevention through basic hygiene and vaccination is such a powerful tool.
It really is.
Thanks for joining us for this deep dive into your source material. We really hope breaking it down like this helps you get the key points straight.
Yeah, knowing the stuff is invaluable, whether it's for exams or just caring for children. It does raise that bigger question, though, doesn't it? How can we better implement simple things like hand hygiene globally to really cut down the impact of this common but potentially serious condition?
A huge question. A lot to think about there. And look, if you are revising and looking for more resources, you might find the materials at pastmsra.com really useful.
And for testing yourself with free practice questions on topics just like this one, definitely check out freemsra.com.
That's all for this deep dive. Until next time.